I want to tell you about a patient of mine. 78 years old, completely independent, walked several kilometers every single morning, sharp and fully in control of his life. He came in for a routine checkup. He left with a referral, then another, then a procedure, then a complication. 6 months later, he could not walk to the end of his street. The original problem would never have touched him. The testing did. If this channel has ever given you something that mattered, hit that subscribe button right now, leave a like, and drop a comment below, because that is what allows this kind of conversation to keep reaching the people who genuinely need it. I'm Dr. Mercer, and this channel exists to bring you the latest evidence-based research on senior health, simplified and designed for adults over 60. Stay with me through this entire video, because by the end you will have 5 specific questions that can genuinely protect your independence, your quality of life, and your health in ways that most patients are never given the opportunity to consider. Let's get into it. Most people over 60 walk into a medical appointment believing, quite reasonably, that more testing means more safety. That finding something early is always better. That the system ordering these tests has thought carefully about whether they make sense for someone at their age and in their specific condition. Here is the uncomfortable truth that took me years of clinical practice to fully accept. The screening guidelines that worked beautifully when you were 50 do not automatically translate to your 70s and 80s. Medicine has been extraordinarily slow to update its rule book for older adults, and that delay is costing people their independence, their time, and in some cases their lives. Here is the concept that changes everything once you understand it. We call it the Cascade Effect, and it is one of the most underappreciated dangers in modern healthcare. It begins innocently enough. A routine scan comes back with a borderline result. Your physician suggests taking a closer look. That closer look finds something else. That something else requires a biopsy. The biopsy causes a small bleed. The bleed needs monitoring. The monitoring reveals an irregular heartbeat. The heartbeat requires medication. The medication causes dizziness. The dizziness leads to a fall. I have watched this exact sequence unfold more times than I can count. A perfectly functional 72-year-old walks through the door for a checkup and 4 months later is managing 3 new diagnoses, 2 new prescriptions, and a fear of leaving the house that was not there before. The risk is real, it is documented in the medical literature, and it is almost never part of the conversation when a physician hands you a referral slip. A study published in JAMA Internal Medicine examined the downstream consequences of incidental findings in older adults and found that 1 in 3 patients who received follow-up testing after an incidental finding experienced at least one significant adverse event from the subsequent workup, not from the original condition, from the investigation of something that may never have caused harm in the first place. That is not a fringe finding. That is a pattern repeated across thousands of patients, and it is why this conversation matters so much. Now let me walk you through the 5 tests most commonly ordered for older adults where the evidence for routine use after a certain age has become genuinely complicated, and where asking the right question before you agree could change everything. The first is routine colonoscopy after 75. For adults in their 50s and 60s, colonoscopy is genuinely valuable. It finds polyps early, it saves lives, and the data supporting it in that age group is solid. But after 75, the calculation begins to shift in ways most patients are never told about. Colon cancer is among the slowest moving cancers we know of. From a small polyp to a clinically dangerous lesion typically takes 10 to 15 years. So if you are 76 and a colonoscopy finds a small polyp today, the realistic probability of that polyp causing you serious harm within your remaining lifetime is quite low for the majority of patients. But the procedure itself carries real risks that increase with age. The preparation alone can cause serious dehydration in a 70 or 80-year-old body. The intensive bowel cleanse required the night before can trigger electrolyte imbalances that represent genuine medical events, not minor inconveniences. Then there is the sedation. Older adults metabolize anesthetic agents differently and more slowly than younger patients. Research published in the journal Anesthesiology has documented both temporary and occasionally persistent cognitive changes following sedation procedures in patients over 70. And there is a real risk of bowel perforation during the procedure itself. In a younger patient, serious but manageable. In a frail 80-year-old, potentially life-threatening. I had a patient, I will call her Marguerite, 79 years old, no gastrointestinal symptoms whatsoever, referred for a routine colonoscopy. The preparation caused severe dehydration overnight. She was admitted to hospital before the procedure even took place. She spent 4 days recovering from the preparation for a test that was scheduled to find something that, statistically, would not have harmed her. The American Cancer Society updated its guidelines to reflect that colonoscopy after 75 should be individualized, weighing overall health, realistic life expectancy, and personal preferences rather than being automatically scheduled. Ask your physician this every single time. If we find something, what are we actually going to do about it? Because if the answer is probably nothing aggressive, the question of why we are doing the procedure deserves a direct and honest answer. The second area concerns cancer screening tests, specifically PSA testing for prostate cancer and mammography for breast cancer in the very elderly. This is the hardest one to discuss clearly, because the fear of cancer is real and the instinct to find it early is deeply human. I understand that completely. But what 15 years of clinical medicine has taught me is this. Finding a cancer and helping a patient are not always the same thing. In men over 70, PSA testing frequently detects slow-growing cases that would never have produced a single symptom. These are sometimes described, clinically and honestly, as cancers you die with rather than die from. But once an elevated PSA result appears, the cascade begins. Repeat testing, then a biopsy. The biopsy carries its own risks, including infection, bleeding, and significant anxiety. If cancer is confirmed, the pressure to treat becomes enormous, and treatment options including surgery, radiation, and hormone therapy each carry serious side effects. Incontinence, loss of sexual function, profound fatigue, bone loss. For a cancer that was sitting quietly and going nowhere. The U.S. Preventive Services Task Force formally recommends against routine PSA screening for men aged 70 and older precisely because the evidence shows the harms of detecting it at that age frequently outweigh the benefits. The same principle applies to mammography in women in their late 70s and beyond. A significant proportion of tumors found at that age are slow-growing, hormone-sensitive cases that are statistically unlikely to ever spread aggressively. Yet finding them often triggers the full treatment protocol. Surgery, radiation, reconstruction. I have seen women in their late 70s go through extensive procedures for tumors that would never have caused them harm. The treatment consumed a full year of their lives. A year of pain, limitation, and fear. This is not a blanket argument against all screening. Some breast and prostate issues after 70 are genuinely dangerous and genuinely require treatment. This is an argument for an honest, individualized conversation before you agree to screen. Ask this before every such test. If this test finds something, what is the most likely treatment path, and what are the realistic risks of that treatment for someone my age and in my current health condition? The answer may genuinely surprise you. The third area is cardiac stress testing in patients with no symptoms. You may have experienced this. You walk on a treadmill while electrodes monitor your heart, or you receive medication to simulate exercise while the same monitoring occurs. If you are over 70 and you have no chest pain, no shortness of breath during normal activity, no dizziness, that test may have opened a door that did not need to be opened. The problem with stress testing in older adults without symptoms is a high rate of false positive results. The test frequently identifies something that appears concerning but is not actually causing harm. And once that flag appears, the next step is almost invariably cardiac catheterization, a procedure where a thin tube is inserted into your arterial system to examine the heart more closely. The risks of catheterization include bleeding, arterial injury, kidney stress from contrast dye, and a small but real risk of stroke during the procedure. These risks are meaningfully higher in older patients. Multiple large clinical trials, including the landmark COURAGE trial published in the New England Journal of Medicine, found that in patients with stable coronary artery disease and no symptoms, surgical intervention with stenting or bypass did not reduce the risk of heart attack or death compared to optimized medication management alone. The surgery did not outperform the pills. So before agreeing to a stress test without symptoms, ask your physician what happens if the results come back abnormal. If the answer involves catheterization or surgery, Ask whether optimizing your medications first might produce equivalent outcomes with dramatically lower risk. The fourth area is bone density scanning and osteoporosis medication in patients over 80. Hip fractures in adults over 80 are genuinely dangerous. Roughly 30% of patients who experience a hip fracture do not survive the following year. So of course bone density matters. Of course we want to prevent fractures. But the way this is being approached in very elderly patients is not always serving them well. DEXA scans, the standard test for measuring bone density, are widely used and largely harmless in themselves. The problem is not the scan. The problem is the almost automatic prescription of bisphosphonate medications that follows when the numbers come back low. These drugs work by slowing bone breakdown, and in the right patient at the right moment, they are genuinely helpful. But in very elderly patients the picture becomes complicated. They can cause serious gastrointestinal side effects including esophageal irritation. And long-term use carries a paradoxical risk, a rare but documented condition called atypical femoral fracture, where the thigh bone breaks not from trauma but from the oversuppression of normal bone remodeling. A medication prescribed to prevent fractures can, in specific circumstances, contribute to one. What the evidence actually and consistently supports for fracture prevention in older adults is different. Muscle strength training, balance work, home safety modifications including grab bars and adequate lighting, reviewing any medications that cause dizziness, ensuring adequate vitamin D and dietary protein. These interventions address the fall itself. And preventing the fall prevents the fracture. A bone density number on a scan will not tell you to install a grab bar in your bathroom. It will give you a figure, and that figure will likely produce a prescription. If a DEXA scan is recommended, make sure the conversation leads to fall prevention strategies first and medication second. Ask your physician directly. What are we doing to keep me strong, mobile, and stable? That is the right starting point. The fifth area is carotid artery ultrasound in patients without any symptoms. Imagine you are 74 years old. You have no dizziness, no weakness on one side, no speech difficulties, no warning signs of any kind. You feel completely normal. Your physician orders a routine ultrasound of the arteries in your neck. The scan returns showing significant narrowing, 70% blockage on one side. Everyone is alarmed. A referral to a vascular surgeon follows. A recommendation for surgery arrives. Here is what is almost never communicated clearly enough in that moment. For patients with no stroke symptoms whatsoever, the evidence for operating on that narrowing is genuinely weak. Multiple major clinical trials have demonstrated that the risk of stroke during the surgical procedure can equal or in some cases exceed the annual risk of stroke from simply leaving the blockage alone with optimized medical management. The surgery intended to prevent your stroke may cause the very stroke it is meant to prevent. The American Heart Association guidelines are explicit. Routine carotid screening in patients without neurological symptoms is not recommended. And yet it continues to be ordered regularly, partly out of habit and partly because finding a narrowing feels like responsible medicine. But responsible medicine means honestly weighing what a finding actually changes. If this test is suggested and you have no symptoms, ask directly. What will we do differently if this scan comes back abnormal, and what is the procedural stroke risk compared to the risk of optimizing my medications instead? You are entitled to both numbers, side by side, before you decide anything. Before I give you the action steps, I need to say something clearly and I need you to hear it firmly. Nothing in this video is a reason to stop seeing your physician, cancel appointments, or refuse tests without discussion. What I am giving you today is information and questions, the beginning of a better conversation. Do not make unilateral decisions about your healthcare based on what you hear here. Take these questions to your doctor and have that conversation with your full medical history on the table. That is where good medicine actually happens. Now, what does the evidence support doing instead of these routine screenings in older adults? The answer involves redirecting attention toward what genuinely improves quality of life and function after 70. Blood pressure management remains critically important at every age. Uncontrolled hypertension damages the brain, the heart, and the kidneys in ways that are entirely preventable. Cholesterol management continues to matter, particularly in patients with existing cardiovascular disease. Vision and hearing assessments are profoundly undervalued. Poor vision is a direct cause of falls. Untreated hearing loss is now linked in multiple studies to accelerated cognitive decline. These simple evaluations carry enormous impact on daily life and independence. Diabetes management, vaccination for influenza, pneumococcal disease, and shingles, these are low-risk, high-benefit interventions supported by decades of solid evidence. And perhaps most importantly, a thorough annual medication review. Taking multiple medications simultaneously is one of the most significant and underappreciated risks for older adults. Ask your physician to justify every single medication you take, every year, and to remove anything that no longer serves a clear purpose for your current health. I want to tell you about a patient I will call Gerard. 73 years old, retired, still physically active, no cardiac symptoms of any kind. His previous physician had ordered a stress test as part of a routine checkup. The result came back with a flag. A catheterization was recommended. Gerard came to see me before agreeing to it. When I reviewed his full profile and the specifics of his result, I recommended against the catheterization and instead proposed an optimized medication protocol combined with a structured cardiac rehabilitation program. That was 3 years ago. Gerard's blood pressure is well controlled, his exercise capacity has improved, and he has not had a cardiac event of any kind. He told me recently that the best medical decision he ever made was asking one question before signing the consent form. He simply asked, "What happens if we try medication first?" Here is exactly what to do with everything you have just heard. Step 1. Before agreeing to any screening test, ask your physician, "What are we looking for, and what will we actually do if we find it?" This single question forces a concrete conversation before you commit to anything. Step 2. Ask specifically, "What is the risk of this test or procedure for someone my age with my overall health profile?" Age-specific risk information is almost never volunteered. You have to ask for it directly. Step 3. Ask what happens if we choose to watch and wait instead. Active surveillance is a completely legitimate, evidence-supported option. It is not giving up. It is choosing wisely with the information available. Step 4. Ask whether the guideline recommending this test was developed using research that included patients your age. Many screening guidelines were built from studies of middle-aged adults and extended upward without specific evidence for elderly populations. Step 5. Ask your physician for a full medication review at least once a year. Ask them to justify every prescription and to discontinue anything that no longer has a clear and current purpose. One important clarification before we close, because this deserves to be said plainly. Everything discussed today applies to routine and elective screening in older adults without active symptoms. If you have chest pain, neurological symptoms, blood in your stool, unexplained weight loss, or any other active and concerning symptom, please seek medical attention promptly. Do not use anything in this video as a reason to delay evaluation of something that is actively bothering you. Symptoms change the equation entirely. The message here is not less medicine. The message is different medicine, medicine designed around what you actually need at this stage of your life. You are not a collection of numbers on a scan. You are not a list of findings on a report. You are a person with a life, and every medical decision should be measured honestly against that life. What does this test change? What does this procedure protect? What does it cost if something goes wrong? Ask those questions. Expect real answers. Nobody in that examination room is going to ask them for you. If this video gave you something to think about, please hit the like button right now, leave a comment telling me whether a doctor has ever ordered a test that led somewhere you did not expect, and share this with someone you love who might be sitting in a waiting room right now without these questions in hand. Subscribe if you have not already, and I will see you in the next one. Take good care of yourselves.